Hello, everybody. Thanks for being here. We were asked to start the webinar 5 minutes past the hour just to give everybody enough time to join the meeting. My name is Alfred Mahr. I'm a rheumatologist in Switzerland in the city of St. Gallen. It's my pleasure to moderate today's webinar. Thanks to the European Reference Network for hosting these webinars. Both the speaker, Maria C Cid, and myself, we are members of the European Vasculitis Society. So today's webinar is devoted to giant cell arteritis, in particular to treatment advances in that disease. We have the pleasure to have as speaker Maria C Cid, which is probably well known to many of you. Maria is a senior consultant at the Department of Autoimmune Diseases at the Hospital Clinic in Barcelona. She also is an associate professor at the University of Barcelona and a senior group leader of a research group called IDIBAPS, also in Barcelona. Maria has extensive track record as a clinical and immunological researcher in rheumatology, more specifically in vasculitis and in particular in giant cell arteritis. And that's the reason why we have the pleasure to listen to Maria today. So Maria, she's both a clinician with a lot of clinical experience and she has a lot of research interest and experience in that disease. Maria, you ready? So thanks for being here.
Thank you.
It's really our pleasure to listen to you. So the presentation will be 30 minutes. That leaves us with 20-25 minutes to answer questions. Please ask your questions for all the attendees using the question section in the pop-up menu of the GoToWebinar tool. So there's a question section, just write it in there and I will ask the question on behalf of you. Thanks a lot. So Maria, up to you.
Thank you very much, Alfred, for this nice introduction. Good afternoon to everyone. I would like to provide an update on the treatment of giant cell arteritis. And I apologize if due to time constraints, I miss some contribution, relevant contribution in recent times. I would like this seminar to be very interactive. Sorry. Excuse me, I have a problem in my screen. Since I am going to talk about treatment, here are my disclosures. Giant cell arteritis has been considered the paradigm of a glucocorticosteroid responsive disease, since high-dose glucocorticosteroid dramatically relieve symptoms and markedly improve blood test abnormalities in the majority of patients. And this is due because glucocorticosteroids effectively halt multiple inflammatory pathways probably operating in this high inflammatory disease. For this reason, glucocorticosteroids are still the cornerstone of remission induction. Unfortunately, as soon as glucocorticosteroids are tapered, the probability of relapses increase. This requires retreatment and prolonging treatment, and this results in well-known glucocorticosteroids-related side effects. Although we have learned to manage and prevent these side effects, glucocorticosteroid side effects are still a problem for patients with GCA, as recently addressed in several important publications. This is an interesting meta-analysis of patient cohorts published over the years. And as you can see here, probability of relapse are are lower in older cohorts compared with more recent cohorts, where investigators have tried to minimize glucocorticosteroids exposure. So the less glucocorticosteroids you give, the higher relapse you get. This is another study focusing only on clinical trials, and again, in trials where cumulative dose of prednisone is lower, the percentage of relapsing patients is higher. Usually, relapses are more frequent in clinical trials that include a rapid glucocorticosteroid tapering than in real life. There are still many challenges in the treatment of giant cell arteritis. About 10 to 17% of patients with visual impairment at presentation continue to lose vision, to deteriorate vision during the first weeks of treatment, which is a very dramatic situation. Between 3 and 6% of patients develop stroke, and more than half develop stroke after the initiation of glucocorticosteroid therapy. Between 18 and 33% of patients develop aortic dilatation over time, with the potential of severe complications. Between 10 to 50% of patients suffer from large vessel stenosis, and between 40 to 80% of patients relapse during glucocorticosteroid tapering, the higher frequency found, as I mentioned, in clinical trials with rapid glucocorticosteroid reduction. Relapses require retreatment and are associated with higher accumulated glucocorticosteroid doses and side effects. So there is an unmet need for more effective and safer therapies in giant cell arteritis. Several broad-spectrum immunosuppressive agents, synthetic DMARDs, have been used in patients with giant cell arteritis in an attempt to spare glucocorticosteroids. These include azathioprine, leflunomide, mycophenolate, and even cyclophosphamide. Among them, only Methotrexate has been tested in randomized controlled trials. This is a meta-analysis of 3 randomized controlled trials performed in giant cell arteritis, some of them with conflicting results. This meta-analysis was performed by my moderator. And in this meta-analysis, what it was seen is that Methotrexate results in reduced probability of first relapse, in reduced probability of second relapse, and in increased probability of complete glucocorticosteroid discontinuation. Methotrexate is widely used in clinical practice in giant cell arteritis. Its use has been supported by observational studies, several observational studies. There is wide consensus that higher or subcutaneous doses should be tested, since in the existing trials, Methotrexate was used in the low, moderate dose range. And a clinical trial comparing Tosirizumab with Methotrexate is currently ongoing. Targeted therapies are addressed to block specific pathways thought to be of relevance in the pathogenesis of several diseases, including giant cell arteritis. This slide summarizes our current understanding of giant cell arteritis pathogenesis, from initial steps in dendritic cell activation, triggering adaptive immune response, to Th1 and Th17 differentiation and macrophage activation, macrophages sustaining and amplifying inflammatory cascades, eventually leading to vascular injury and maladaptive remodeling. Several molecules are involved in these basic processes, and many of them have been the target of targeted therapies. All the treatments listed in this slide, blocking specific molecules, have been tested or are currently being tested in giant cell arteritis according to the clinicaltrial.gov .gov website. Some of the targeted molecules participated mainly in Th1 differentiation, others mainly participate in Th17 differentiation, and others in macrophage activation, and some of them act at different levels. From these molecules currently, from these treatments currently in development, I will primarily discuss randomized, those that have been tested or are currently being tested in randomized control trials, mostly Tosirizumab, Mavrilimumab, Abatacept, and TNF blockers. Abatacept is a recombinant molecule, CTLA-4, that prevents CD28-mediated activation during initial steps in adaptive immune response, and probably this abatacept will act at initial steps in the inflammatory cascade leading to giant cell arteritis. Abatacept has been tested in a phase 2 clinical trials, including 41 patients. And the primary endpoint of this trial was sustained remission at 12 months, and abatacept was slightly more effective than placebo in achieving this primary endpoint. A phase 3 randomized control trial is currently ongoing. This trial is investigator-sponsored, and the leading investigators are Carol Lamford and Peter Merkel. So TNF blockers were the first biologic agents ever tested in giant cell arteritis. Unfortunately, 2 phase 2 clinical trials did not show any sign of efficacy in newly diagnosed patients at the expenses of more side effects, mainly infections. Another trial was too small to yield meaningful results. So the IL-6 pathway can be blocked by interfering with interleukin-6 receptor, such as Tosirizumab or Sarilumab, or interfering with IL-6 cytokine itself, such as Sirukumab and other IL-6 blockers. All these 3 have been tested in giant cell arteritis. All these 3 monoclonal antibodies entered phase 3 clinical trials, but only the clinical trial with Tocilizumab was completed. The other clinical trials with Sarilumab and Sirukumab were terminated by the sponsor, not because of safety reasons. And preliminary data from one of them has been recently published, data from Sirukumab trial. A phase 2 trial with intravenous Tocilizumab was published in 2016. This trial enrolled 30 patients, 20 to Tocilizumab and 10 to placebo, and the primary endpoint was relapse-free survival at week 52. Tocilizumab yield dramatic benefit in this clinical trial, as you can see in this graph. But we have to take into account that definition of relapse, and that CRP values were part of the definition of relapse and were not blinded to investigators. So this may have favored to favor Tocilizumab arm. The phase 3 Giacter trial with Tosirizumab, the largest trial performed so far in giant cell arteritis, enrolled 250 patients. These patients were randomized to receive Tocilizumab subcutaneous every week or every 2 weeks, along with a 26-week prednisone taper, or to placebo with 26-week prednisone taper or 52-week prednisone taper, followed by an extension period. This trial recruited newly diagnosed and relapsing patients, and the primary endpoint was percentage of sustained remission at week 52 with total adherence to the prednisone tapering schedule. So the trial fulfilled spectacularly also the primary endpoint, and more than 50% of patients in the Tosirizumab arm were able to endure sustained remission at week 52. So sub-analysis showed that weekly administration was better than every 2 weeks for relapsing patients in this trial. Time to relapse also favored Tocilizumab over placebo. Cumulated glucocorticosteroid doses were significantly lower in the Tocilizumab arms. So side effects were balanced among groups, and there were no deaths or irreversible visual loss in this important trial. So this trial led to the approval of Tosirizumab for the treatment of newly diagnosed or relapsing patients. Since then, there has been substantial experience accumulated in clinical practice around the world, and several papers have been published. So these papers include a higher proportion of relapsing patients than in clinical trials, and a higher proportions of pretreated patients that were given Tocilizumab because of high risk of glucocorticosteroid side effects, or because of developing already these side effects, and because Tocilizumab has some restrictions in some countries. In real-world clinical practice, the percentage of responders is higher because the response criteria are not so stringent, and frequently Tocilizumab is an add-on treatment with and patients are not and concomitant glucocorticosteroid or DMARDs are not completely discontinued, although usually a reduction in these agents is observed. In clinical practice, there is also more side effects, perhaps because of the load of previous or concomitant medications. There are many open questions for the treatment of Chancel arteritis with mepolizumab, with Tocilizumab. A very important one is for how long. So this is the extension of the phase 2 trial. And this actually in this extension phase, only 17 were evaluated, and only 9 remained in remission. So this is the extension of the Giacter trial beyond the 52 weeks, where the primary endpoint was evaluated. From the 150 patients that received Tocilizumab, 125 entered part 2 after the 52 weeks. From these, 52 entered part 2 in treatment-free remission. And from these, 42% ended part 2 in treatment-free remission. So, so this has two interpretations. One is that as soon as you discontinue Tocilizumab, probability of relapses increase, and the good lecture is that more than 40% of patients are able to maintain treatment-free remission of those who initially responded. In this extension phase, weekly Tocilizumab seems to have also better efficacy. In the extension phase, accumulated prednisone was also significantly lower in the Tocilizumab arms, particularly in the weekly Tocilizumab. Patients initially randomized to Tocilizumab weekly. Another important question is the assessment of disease activity, because of its mechanism of action, Tocilizumab abrogates detection of CRP, or highly reduced concentrations of CRP, and this useful marker along with ESR are widely used for a patient evaluation, and they are very useful when patients have only minor symptoms for the clinician. So this study actually explores how were the relapses in patients enrolled in the Giacter trial. And as you can see here, 92% of relapses in the Tosirizumab arms occurred with normal CRP. So they were clinically based, essentially. However, 34% of relapses in the placebo-treated patients also happened with normal CRP. This may be a little bit lower in clinical practice because since physicians were blinded to CRP, probably they were afraid of relapses in patients with minor symptoms. There is another interesting question, is whether Tosirizumab masks or controls the disease. Tosirizumab has a deep impact on the systemic inflammatory response, which is a strong source of discomfort for patients with GCA, with fatigue, fever, weight loss, malaise. All these symptoms are relieved by Tosirizumab. Does Tosirizumab mask or control the disease? What's the impact on vascular inflammation? This is still not very well known, but there have been several studies assessing the effect of Tosirizumab on vascular inflammation detected by imaging. These are results from patients enrolled in the phase 2 trial with Tosirizumab. Imaging was not part of the trial, but some patients underwent magnetic resonance angiography. Only 9 patients receiving Tosirizumab and 4 receiving placebo were imaged. And as you can see here, some patients improved at 3 months, but some patients that improvement was not sustained. So it's unclear results, probably because of the low number of patients. These are PET results in selected patients included in the Giacter trial. PET was not part of the outcome measures of the Giacter trial, but some patients were imaged at the participating centers. So in spite of the high heterogeneity regarding the performance of the PET itself or the timing where the PET was performed, a significant reduction in FDG uptake was seen in the left subclavian artery in these patients, and a tendency to decrease in other territories. There are other small studies assessing the imaging, the PET imaging in receiving Tosirizumab, and you can see here in this paper you see a nice reduction in PET in FDG uptake and the total PET vascular score. This is a recently published paper enrolling 25 patients, the largest study so far with this purpose. And you can see a progressive reduction in PET vascular score in patients receiving Tosirizumab. And as soon as you discontinue Tosirizumab, you can see that PET VAS increases again in some patients. Ultrasound has been also used to evaluate response to Tosirizumab in a recently published study with a few patients. As you can see here, the halo thickness assessed at different temporal artery branches and axillary artery decreases in some patients, as well as the halo score in these patients. Another important question is what's the impact of Tosirizumab on vascular remodeling and occlusion, and what's the impact on delayed aortic complications? Although there have been several case reports of visual impairment improving or worsening with Tosirizumab, or aortic aneurysms developing in patients with Tosirizumab treated patients, the experience is still very scattered to allow any answer to these important questions. Another interesting question is, can Tosirizumab be administered in monotherapy? There are 2 studies, as far as I know, trying to answer this question. This study was performed in a mixed cohort of giant cell arteritis and Takayasu patients, and only 7 patients with giant cell arteritis were included. These patients received only intravenous Tosirizumab every 2 weeks at the beginning and every 4 weeks after week 12. And as you can see here, this achieving complete response was delayed, was more delayed than in clinical practice, and did not happen in all patients. So these patients are at risk of potential complications. So the effects are not very encouraging. This is another study that was presented at the past ACR meeting. And in this study, 18 patients were included. These patients were treated also with IV Tosirizumab after receiving 3 IV pulses of 500 milligrams of methylprednisolone and no additional glucocorticosteroid. And as you can see here, a remission is slowly achieved and not happen in all patients. And actually, in this small cohort of patients, there was 1 irreversible visual loss. So Tosirizumab has been a major advance in the treatment of giant cell arteritis, has been approved by several regulatory agencies for the treatment of new or relapsing GCA. Weekly Tacilesuma seems more effective than every other week, particularly for relapsing patients, and in the long term, nearly half of patients, however, relapse when glucocorticosteroids are completely withdrawn. And sustained treatment-free remission can be expected in 42% of responders. So there is still a way to go. And current data do not support monotherapy at this point. GM-CSF is emerging as a key player in chronic inflammation. And mavrilimumab is a monoclonal antibody targeting the alpha chain of the GM-CSF receptor. GM-CSF receptor leads to STAT5 activation and also to the activation of an important transcription factor for amyloid cell activation. And these 2 transcription factors regulate each other and regulate the expression of genes that are very important in T-cell activation and differentiation, and in macrophage function and granuloma formation, and may have a role in the pathogenesis of giant cell arteritis. GM-CSF is known to be expressed in giant cell arteritis tissue from the 90s, from the mid-90s. This is a study where GM-CSF was detected by classical RT-PCR in a small patient cohort. Here control, and here GM-CSF. More recently, we have been able to confirm GM-CSF transcripts in tissue from giant cell arteritis patients by quantitative real-time PCR, and also the expression of the receptor in giant cell arteritis lesions. GM-CSF and its receptor can be expressed in GCA lesions by a variety of cells, but more intensively by macrophages and endothelial cells. Treatment of ex vivo culture GCA arteries with mavrilimumab leads to reduction of GM-CSF regulated molecules such as CD83, a marker of dendritic cell activation, or the relevant transcription factor PU1. Treatment with mavrilimumab also results in reduction of select infiltrating cell subsets in GCA arteries, culture ex vivo. In a phase 2 clinical trial with mavrilimumab for the treatment of giant cell arteritis has been recently completed. This trial enrolled 60 patients. Half were newly diagnosed and half were relapsing patients, and were randomized 3-2 to receive mavrilimumab 150 milligrams sub-Q every 2 weeks, along with 26 prednisone taper, or placebo, along with the same period of prednisone taper, the primary endpoint was evaluated at 26 weeks. So the trial fulfilled its primary efficacy endpoint, which was time to first relapse. Mavrilimumab treatment resulted in a 62% risk reduction compared to placebo. Sustained remission at week 26 was achieved by 83.2% of patients in the mavrilimumab arm compared to about 50% of patients in the placebo arm. So these results are highly encouraging for further development. So as a take-home messages, glucocorticosteroids are still the cornerstone of remission induction in giant cell arteritis. Reducing relapses as well as glucocorticosteroid exposure and side effects are the main goals of new therapies. Among immunosuppressive agents, methotrexate has demonstrated a modest effect in reducing relapses and glucocorticosteroid exposure in giant cell arteritis. The use of anti-TNF agents is not recommended for patients with giant cell arteritis. The efficacy of abatacept supported by a phase 2 trial needs to be confirmed in larger studies. IL-6 receptor blockade with Tosirizumab has demonstrated efficacy in reducing relapse, glucocorticosteroid exposure and side effects, and restoring quality of life. Existing data do not support its use as monotherapy, though. More follow-up data are needed to assess optimal duration of treatment and its impact on vascular complications. More than 50% of patients may not sustain treatment-free remission, and other therapeutic options need to be investigated. Mavrilimumab has demonstrated to prolong remission and reduce relapse rate in a phase 2 randomized control trial. Randomized control trials with other targeted therapies, secukinumab, which is anti-IL-17, and anakinra, which is an IL-1 receptor antagonist recombinant, uselkumab, which is an anti-IL-23p19 antibody, and upadacitinib, which is a JAK targeting mainly JAK1, are currently ongoing and may expand soon the therapeutic armamentarium for patients with giant cell arteritis. Since I presented some recently obtained results, I want to acknowledge the contributions of current members of my group and our funding agencies. I would like to underline the contribution of Mark Corbera, who did the preclinical studies, and Georgina Spiegel and Robert Rios, who are seminal in our participation in the phase 2 trial, the mavrilimumab phase 2 trial, and also in the Giacter trial. Thank you very much for your attention.
Thank you, Maria. So we give you a huge virtual applause. Thanks a lot for this great overview. So we have 20 minutes left for questions and answers. For now, we just have one single question from the attendees, but there may be more questions coming in. Maybe I could start asking a first question. You clearly highlighted that we have many more options today to treat giant cell arteritis than it was the case 15 or 20 years ago. In the end, could you give us an estimate of the proportion of patients that you treat for giant cell arteritis who get a medication on top of glucocorticoids? Is it 30%, 50%, 80%, 100%? What proportion of your patients with giant cell arteritis are treated with glucocorticoids alone?
I would say that for the moment, we are using glucocorticosteroids in my particular experience. We use glucocorticoids alone. We have used glucocorticosteroids alone maybe in the majority, but perhaps 40% also receive something else. Regarding Tacilesuma, we had some restrictions in the public health system. So we are allowed to use Tosirizumab in patients that are relapsing, multi-relapsing patients, or patients with side effects, or patients with anticipated high risk of side effects. So this is the current picture, but this current picture is going to be probably quickly evolving. Yeah.
There's a question from the audience thanking you for the presentation. The question is, would you recommend Tacilesumab every other week in newly diagnosed giant cell arteritis patients? So not in relapsing patients, but newly diagnosed. If you started right away Tacilesumab, would you recommend every other week therapy?
Well, the numbers favor weekly Tosirizumab for relapsing, definitely for relapsing patients. And in the long-term follow-up, there is a signal that patients initially randomized to weekly actually have better benefit. What I have usually done is to start with every 2 weeks, but because of economical reasons mostly, but as soon as I don't see satisfactory response, I escalate to every week.
There's another question from the audience, a person apologizing for the basic question. The question is, why is it called arteritis and not arthritis?
Arteritis and not arthritis?
Yes, that's the question.
Is that the question?
Yes,
Yeah,
it
because
is.
arteritis actually is a good definition of the disease, because itis means inflammation, and this disease is characterized by inflammation of arteries, medium-sized and large arteries. So there is an inflammation of arteries, whereas arthritis would refer to inflammation of joints. In giant cell arteritis, we don't see inflammation of joints very often. We do see synovitis of mostly of periarticular structures, bursitis, tenosynovitis in patients with so-called polymyalgia rheumatica that happen in about half of patients with giant cell arteritis. But probably the term arteritis better defines the disease.
Thank you. There's another question. If there's any sign of a replacement drug for glucocorticoids, since there are so many side effects of glucocorticoids. So I think we all understood you well saying that glucocorticoids are still sort of mandatory for the treatment of giant cell arteritis. Are you seeing something on the horizon that might get us to a glucocorticoid-free therapy regimen for giant cell arteritis?
So actually, this has been achieved for some patients with ANCA-associated vasculitis, but not yet in giant cell arteritis. For the moment, all clinical trials have been performed as remission maintenance trials. So patients have entered the trials or in glucocorticosteroid induced remission, or at least with a load of high dose glucocorticosteroids. So, so all conclusions can be drawn for patients that have received an induction therapy with glucocorticosteroids. This is one reason that at the moment I don't see any alternative for induction of remission, an alternative to glucocorticosteroids. From the physiopathological point of view, as illustrated by the Giacter trial, so blocking IL-6 may be very relevant for giant cell arteritis patients, but apparently not for all of them. So there are many pathways operating in giant cell arteritis, and maybe blocking one pathway, only one pathway from the very beginning, would not completely abrogate vascular inflammation and this can be dangerous for this disease because of the potential of severe ischemic events. For instance, this is mainly the reason, because perhaps it's too naive that blocking one pathway would be enough for all patients. So I think this initial shock with glucocorticosteroids is important, and then target relevant cytokines in sustaining some degree of vascular inflammation. So we know that in rheumatoid arthritis, for instance, Tosirizumab works well as monotherapy, but probably patients with rheumatoid arthritis do not have such a strong inflammation as patients with giant cell arteritis. They don't have the potential of these life-threatening or complications.
Thank you, Maria. So the hope might be combining different biological DMARDs or differing DMARDs, and that could be the solution to treat giant cell arteritis without glucocorticoids. Do you have any experience with combining Tacilesuma and Methotrexate to treat giant cell arteritis?
Yes, I have experienced Methotrexate treating. Sorry, could you repeat the question, because I had some disruption in the.
Sorry,
so I didn't hear you very well. Could you? No.
Some people have experience with combining Tosirizumab and Methotrexate. They tried to combine these both disease modifying agents. Do you have experience with it?
I don't have personal experience with that outside the Giacter trial. In the Giacter trial, there were patients receiving Methotrexate, and so this Methotrexate was not an exclusion criteria to be randomized, to be included in the Giacter trial. However, the proportion of patients that were receiving Methotrexate was too small to drive any conclusion about what was the effect of Methotrexate in the endpoints, in the measure and endpoints. So I don't have experience with the combination of two. I have experience in patients that were receiving Methotrexate and then were switched to Tosirizumab.
Over the last years, we have been talking a lot about Tacilesuma, obviously, and there's strong data, and the drug has been approved for the treatment of giant cell arteritis. What's your thought or position about synthetic DMARDs? So you mentioned Methotrexate. Some colleagues also use azathioprine, mycophenolate mofetil, cyclophosphamide in very selected patients. Is there still any room for these agents in your practice?
So my experience with these drugs is very limited. I have used azathioprine in a few patients, but actually they were unlucky to have side effects. And then I don't have experience with other DMARDs. I have always used mostly Methotrexate. So actually the evidence supporting these agents is weak, because it's based mostly in observational studies. These observational studies sometimes are performed on refractory patients. I am thinking on a few cyclophosphamide observational studies. I don't think cyclophosphamide should be an option for these patients, at least maybe for very particular patients, but not something that we would generally consider for these patients at all. Actually, the studies on cyclophosphamide are of refractory patients, but these patients, some of them don't have even a biopsy or imaging supporting the diagnosis. So I wonder whether a part of these so strongly refractory patients had another condition. So I really don't use other DMARDs other than methotrexate in my particular experience, in my particular practice. I have used azathioprine in a few patients.
So there's another question from the audience. So that question popped up by the time you mentioned the CRP values, normal CRP values in relapses in the Giacter trial. So you said that 92% of the relapses in Giacter in Tosirizumab treated patients were actually by the time of normal CRP. So I think the question I'm just telling you has to be viewed in that context. So the question is, how is a relapse defined?
How was relapse defined? Yes, the relapse in the Giacter was defined as the appearance of symptoms of GCA or PMR or large vessel related symptoms, as well as elevation of ESR and also CRP, but CRP was blinded to investigators. So CRP was used to calculate the primary endpoint, but actually there was a sensitivity analysis excluding CRP, and the numbers were quite similar, were very similar.
But in your clinical practice, I mean, in Giacter, people were blinded to the laboratory values for understandable reasons. In your clinical practice, are there many patients diagnosed with a relapse of Chancel arthritis with strictly normal lab values?
Well, actually, we may have other things that sometimes we routinely determine, such as platelets, but platelets are not elevated in many patients, so can be used in some patients only. Then we use also haptoglobin. We use actually ESR is not so much abrogated as CRP. So actually we are in need of additional clinically validated biomarkers for patients treated with Tosirizumab.
But outside the field of Tacilesuma,
outside the field of Tosirizumab, I think ESR and CRP are very useful. Because sometimes patients complain with headache. I mean, headache is a very common symptom, and headache can be a symptom of anemia, which is common in all patients, particularly patients receiving antiplatelet or anticoagulant agents. Sometimes they have ferropenic anemia that sometimes is not microcytic. So anemia is common in this patient population, and so anemia causes headache. For this, and anemia elevates ESR, for instance, independently of inflammation. So for these patients, CRP is very useful. When you see a headache, a slight headache, so you cannot immediately define relapse in clinical practice. You usually wait to see whether this headache is more intense, more persistent, has more additional traits of facial pains or scalp tenderness or other kind of pains that are more typical of GCA. But if this small headache is accompanied by increase in CRP, this makes this is stronger to make decisions. And the same with some proximal symptoms suggestive of PMR. So all patients had a lot of tendinopathy, sometimes in the shoulder. So sometimes patients may complain of shoulder pains or shoulder limitations. If you have increasing CRP, so this is very useful for the clinician actually. So clinician we usually clinicians detect easily strong relapses or moderate relapses, but slight relapses, acute phase reactants are very useful if they are steadily increasing.
Maria, there's one question about what you do by the time you stop Tosirizumab in a patient doing well, and the patient is not treated with glucocorticoids any longer. Would you just stop Tosirizumab, or would you introduce another DMARD at that stage? I guess the question is whether we would start Methotrexate or something else.
Yeah, this is a very relevant. Relevant question. Actually, the patients I have with Tosirizumab, they are still on it, so I cannot answer this question from my personal point of view. But we have data from the trials and from clinical practice. And actually, when Tosirizumab is discontinued in patients that are doing well, so we may be ready to expect relapses in at least half of them. So, and what happened, in fact, is that patients treated with Tacilesuma actually have elevated IL-6 because some feedback mechanisms are broken. So if the patients have the receptor blocked with Tacilesumab, they have elevated IL-6, and they have increased IL-6 receptor as well, soluble. So as soon as you release the brake, so the patient is in a situation of activating the IL-6 pathway because they have sometimes elevated IL-6. So maybe this the idea you point out, and all that other experts in the field have expressed, is that maybe at the time of discontinuation we should be given a little bit of glucocorticosteroids that could be subsequently tapered. That could be an option, just because when we stop Tosirizumab, we release a brake on a otherwise potentially activated IL-6 pathway. So there are no strong data about what should be the policy at the time of discontinuing Tosirizumab, but adding a DMARD or a small glucocorticosteroid dose perhaps is not, it's a good idea. I don't know, we need more experience on that.
One personal question from the audience, for your clinical expertise, what percentage of people who are treated only with high-dose steroids go into extended remission? So how many people are you able to cure with steroids alone?
I would say that with steroids alone, completely discontinued, or at very low doses such as 2.5 milligrams a day, or in fact in less. I can ask that question for patients receiving less than 5 milligrams, and probably about 2.5 or 0. About 40% of patients have sustained remission in our experience with glucocorticosteroid alone in the long term.
We have been talking about other investigational agents we have less data for. So the question is, when you have a patient who has a relapse, visual relapse, after having had prednisone, methotrexate, and tocilizumab, what would be your next option?
The first thing would be, so you mean when a patient has failed methotrexate and has failed tocilizumab? Is that your question?
Yes.
Yes. So the first thing I would do is to reconsider diagnosis, to make sure that the patient has Chancel arteritis and does not have another vasculitis, for instance, that sometimes may affect the temporal artery, or if the patients really have confirmed Chancel arteritis.
Maria, still here?
When or yeah, I can. Are you hearing me?
Yes, now we hear you
Excuse
again.
me?
Sorry. Yes.
Okay. So the first thing I would do when patient fails two options is to make sure that the patient has GCA and reconsider the grounds on which the diagnosis has been made, because sometimes we have surprises. The second thing I would do in these patients would be trying agents that have given a signal of efficacy, and this would be obviously I am talking about compassionate use, and this would be abatacept, this would be ustekinumab, this would be mavrilimumab.
Thank you. So last very quick question. We need to wrap it up, but I have a very small question. We talk a lot about personalized medicine in general. So giant cell arteritis is a heterogeneous disease, has become a heterogeneous disease. There's cranial phenotype and the large vessel phenotype. Does this influence somehow your treatment decisions, what the phenotype is, or would you at this time treat all the patients with the same regimen?
So I know that what I am going to say maybe is not shared by all the GCA experts of investigators, but I am against deep dichotomy between cranial and large vessel GCA, because according to my experience and experience of other investigators, is that the great majority of patients have both. They have cranial symptoms, but if you image them early after the diagnosis, before glucocorticosteroids, or early after glucocorticosteroid initiation, you see that large vessel involvement is present by imaging, which implies that histological level probably is more, but it's present large vessel involvement in 70% of patients. So probably at the histopathological level is even more, if not all. Certainly, there are patients that don't have cranial symptoms, but still a percentage of them have a positive biopsy, even with no cranial symptoms. And they are definitely patients that don't have a cranial involvement detectable by biopsy or by imaging. But these are the minority. I think there is a deep heterogeneity in the literature about what do we mean by large vessel GCA or cranial GCA. Do you mean large vessel GCA to any patient that imaging reveals large vessel involvement? Or do you mean large vessel GCA to patients that don't have a positive temporal artery and they don't have cranial symptoms, of course, or don't have temporal artery biopsy or any sign of cranial artery involvement by ultrasound? So I think what happened is that there was a sudden awareness that many patients with GCA could have large vessel involvement, and that led to this dichotomy. But this dichotomy is real for a minority of patients only. What happens is that the edges of the spectrum has some peculiarities. So the age of purely cranial GCA used to tend to be old and tend to respond better, tend to have more visual complications. The end of the spectrum of large vessel involvement or pure large vessel involvement usually are younger patients, and usually they may have more refractory disease. So the disease is like a spectrum, and the ages exist by I would say that are the minority of patients. But certainly from the molecular level, GCA is going to be probably an heterogeneous disease, And targeted therapies will help to delimitate these different pathways that may be more active and in some patients respect to others.
Maria, thank you so much. I enjoyed this a lot, and I think other people as well. I'm a little unhappy with all of a sudden we have many questions popping in, but we have to stop in here. Maria, thank you so much. This was great. Both of us thank also ERN-RITA for setting this up. A small announcement is that the next webinar is going to take place in February, but the date has not been set up at this time. The topic will be about primary immune deficiency. I think that's all. Is there anything else you would like to say, Maria?
So no, thank you very much for your attention. Thank you very much for all the interesting questions you have raised. And keep learning and keep practicing and keep contributing to this fascinating field. Thank you.
We'll maybe try to answer some of the unanswered questions in the live session by writing. We'll see if that's manageable. Thank you so much for attending. Thanks, Maria. Wish you a good afternoon and a good weekend. Bye-bye.
Thank you. Bye-bye.